presentation. My name is Leanne Loranger, and I'm speaking to you today from Edmonton. I would like to begin today's webinar by acknowledging that the College of Physiotherapists of Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. The College of Physiotherapists of Alberta recognizes that Indigenous peoples have been helping many to live healthy lives on this land since long before settlers arrived. With that, we commit ourselves to helping move people forward in their journey towards a good life, and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today, and we encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. And now it is my great pleasure to introduce our speakers for this third session in our evidence-based practice webinar series. This morning's presentation is divided into three presentations. So Eric Perrant will start us off answering the question, are the results of this clinical trial or meta-analysis statistically and clinically significant? Then he will go on to talk about odds ratios, risk ratios, and number needed to treat. And finally, Doug Gross will bring us home with a fresh look on evidence-based practice. So with no further ado, I will turn it over to you, Eric.
So it's a pleasure to be here to review with you how to judge if the results of a clinical trial or a meta-analysis are statistically or clinically significant. This will remain an important skill to have for you to practice evidence-based practice so that you can combine the best available evidence with your clinical knowledge and your client values, because the evidence accumulates very quickly. I illustrate here the number of RCTs and meta-analysis that have been published on physical therapy, and the blue line illustrate when I graduated. So clearly, if I am not able to interpret evidence as the time passes by, I will quickly become outdated. So the focus of my presentation is going to be on determining what are the results of therapy type evidence, and at the top of our evidence of hierarchy for this type of evidence, we have the systematic reviews, the meta-analyses, and the RCTs. So we want to know, as we read those, how large was the treatment effect that was reported, how precise was it statistically and clinically significant, and that's what we're going to present. During our last presentation, I touched on tools that we can use to assess the quality of therapy type articles, and in the Pedro scale and in the Cochrane risk of bias scale, there was questions related to determining if the appropriate analysis had been used and if the studies had reported both specific estimates of the measurement and the variability on key outcome, and did they apply selective reporting, so did they cherry pick which analysis they were reporting or not. And so we're going to review how to answer those questions. The choice of the right analysis will depend on the kind of variables you're dealing with. So first in my presentation, I'm going to focus on the continuous outcome variables. And so they can have a value anywhere over a continuum. Examples of what we use in physios include range of motion, strength measurements, weight, walking distance, or speed. And there's also examples of questionnaire scores that are not purely continuous, but we analyze them as continuous. And those include long ordinal scales from questionnaires, the numeric pain ratings, or counts of common events. So we're going to use that. So when we summarize the information on our continuous variables, the most basic statistics we're going to be looking for are point estimates of the effect. So what's the best estimate of the effect based on the sample we were dealing with? And that's the mean that's going to tell us that. We're also going to look for estimates of the variability, and oftentimes it will be reported as a standard deviations. And that will help build some confidence intervals. And the confidence intervals are going to be very useful for our interpretation, because we can say for every 100 repeated experiments, 95 out of 100% of these point estimates will be contained in the original 95% confidence interval. So the confidence intervals are going to be useful to help us judge the statistical significance, the range of probable value if we were to repeat this experiment, and generally how precise the result of the experiment that's reported to us was. So that's more valuable than the p-values. Occasionally, we'll encounter medians and interquartile range. That's less common, and I'm going to spend less time talking about that. So let's review how we can use these confidence intervals to determine the statistical and the clinical significance. For that, we'll use an example. So let's say we have a study that reported in one group what was the mean post-treatment pain reduction on a 10-point visual scale, and they gave us a 95% confidence interval. So the mean could have been 4, the confidence interval going from 3 to 5. And then we can see, first question, does the confidence interval for the mean difference from baseline to post-treatment include 0? If we answer no, and that's the case here, we will say it was a statistically significant effect. Then we can ask the next question. Is the mean difference larger than a clinically important threshold? So we can look that the mean of 4 is larger than the clinically important threshold for pain reduction of 2, and here we would conclude the results were also clinically significant. So let's examine what we would answer for these two questions if instead we had a mean of 1 with a confidence interval spanning 0 going all the way to 2.5. So to the question, does the confidence interval include 0, we would have to say yes and conclude that no, these results are not statistically significant. And then, is the mean difference larger than the clinically important threshold? No, our observed mean is 1 and it's smaller than 2, so we would also conclude here this is not clinically significant observation. One of the difficult things to do for us clinicians is to determine what is the clinically important threshold before we can conclude that it was clinically important effects. So we recommend that when you can, you use the minimal clinically important difference, and that's defined as the smallest amount that an outcome must change before it's meaningful to patients. Such estimates of that are available on the Shirley-Ryan Ability Lab for different outcome measures in different contexts. If that's not available, you can try to look for a minimal detectable change value, but that refers to the minimal amount of change outside of the error range that could be interpreted as reflecting true change for a patient between 2 time points. So that could be valuable. The MCID is not a one-size-fits-all. It's been said to differ depending on the outcomes tool and the population characteristics or the context of the measurement. So it's worth looking at databases to try to find good values for that. Sometimes we don't have many choices, but we have to remember that these MCID thresholds, minimal clinically important difference, are proposed to be applied at the individual level. So we would use that to judge if one patient has changed by a clinically important amount rather than looking at the mean of a group. But when we review the RCTs, the reviews, the meta-analyses, oftentimes they report group differences between intervention. If we don't have better information, then yes, we can apply the MCID and interpret whether the mean change reached the threshold. But it doesn't mean that even if the mean change does not reach our threshold, that there isn't a big group of patients that would have changed by this important threshold. So if you have that information, it would be nice to look at the proportion of the patients that did benefit from the treatment by a quantity equal or larger than the MCID. And we'll talk about that in the second part of this presentation. The Rehabilitation Outcome Measure database is a good source to find MCIDs or thresholds of clinical importance, but otherwise I list here a number of places where I found some other sites listing that kind of information. Now there's still a number of tools where we haven't documented what is the right MCID or MDC value to use as a threshold for clinically important differences. And so it's been recommended that sometimes when you don't have better information, a good rule of thumb would be to expect a change of about 30% from the baseline score as a guide for judging whether the changes are clinically important. And so you would do the post-treatment value minus the baseline value divided by the baseline value to obtain a percentage of change from that baseline value. And 30% has been documented as possibly indicative of a clinically important change. So now we can try to look at what is the right statistical test to use. And so for a typical RCT, we oftentimes measure 2 groups of patients at baseline, and we remeasure these 2 groups of patients at follow-up, and we can have a change estimates over the trial. So one strategy would be to compare what are the post-treatment results means in one group compared to the other. That could be done with an independent t-test. The problem with that is it ignores the baseline data. So it may not be the ideal. We could compare how much change occurred in one group to how much change occurred in the other group, and if we find that the experimental treatment group changed more, that would be good. We could do that with independent t-test, and the problem, though, is that it ignores whether our patients started with similar values or not, and so it might be hard to interpret. Another strategy would be to compare in each of the group. Was there a significant change from baseline to discharge in one group? You could do that with paired t-tests in that group, and then do another paired t-test in the other group and see was there a significant effect in each of the group. But it doesn't use all the data or compare it if one change is bigger than the other one. And therefore, it might be better to use an ANOVA, which would compare both the baseline means and the post-discharge mean in this study. And so there, you could do with an ANOVA also a test of how big the changes are in multiple groups tested over more than 2 time points. So the ANOVA is something you're going to encounter a lot in studies of the effect of therapies in physiotherapy. And so the results of those will typically be reported with 3 p-values. So your ANOVA will present to you a group by time interaction, a group effect, and a time effect. What we care about mostly is, was the group by time interaction significant? Because it would show that the pattern of change over time is different in some of the groups than the others. So here, if we're comparing an exercise group to a medication group to a control group, we could find that both the medication and the exercise group seem to have a different pattern. And so if the group by time interaction effect was significant, that's what it would show, is that somewhere between those means of these groups, the pattern's different. So then we would need to go one extra step and look for the pairwise comparison to look at pairs of means and say, where are the significant differences? And that's what we would care about. If we only found a group effect, it would be that over time there's no change between groups, but there's difference between the groups overall, but not over time. It doesn't change over time. If we only found a time effect, but not a group effect, it would show that every group changed similarly over time. So it's not that useful to show that a new intervention is better than another. The group by time interaction is really what we'll care about. So in our 3 group with 3 time points example, if our group by time interaction was significant, we would be looking for what is the pairwise comparison table. And so it would be a table presented in the article reporting what was each of the means at each of the time points for each of the groups. And so we could start looking at what is the mean in the confidence interval for group A, and was it statistically significant from the mean B at their post-treatment time. And so we would be able to judge in this group, in the medication group, was there a difference from baseline to post-treatment by looking at whether the confidence interval of the first mean included the evidence for the group B. And here the confidence intervals do not overlap. We would conclude, oh yeah, mean B was lower than mean A, and there was a good effect. And so we can continue on and compare each pair's mean in our pairwise comparison using the confidence intervals to draw our conclusions. Sometimes the table of pairwise comparison will be presented differently. It will show for each mean compared to all the other means whether the difference was statistically significant or not. So if we look in the table here, we show that mean A was compared to mean B, C, and D, and they were all significant because the p-value for that pairwise comparison was less than 0.05. And same, if we look in the group of exercise, the mean D was significantly different from a number of other means. And so that would be useful to see where the treatment effects are in the trial. To help us answer the question from the appraisal guides about was that the right statistical analysis that was used, there are some decision trees that we can use. And so in the middle there, if we're trying to find what is the difference between 2 groups, we can answer the question, was the data paired between samples? So for example, if we're comparing the baseline to the post-op data, if it comes from the same subject, we would say it's paired, and then it would suggest the paired sample t-test would be adequate for comparing the baseline mean to the post-test mean. If the data was impaired, so let's say we're comparing the change in one group to the change measured in the other group, we have two means and they come from different subjects, we could use a two-sample t-test to compare those. The example I was reviewing is when we have differences between more than two groups, then we can check, okay, we have three groups, and maybe we also have 3 time points. So this would be adequate for a two-way ANOVA. And then if our interaction is significant, we would look at our multiple comparison. Otherwise, we would look at the multiple comparison specifically to the factors that were significant, and that would be the two-way ANOVA model. If we were only comparing the change that we observed from baseline to follow-up between our 3 groups, we would have a group factor with 3 levels, medication, exercise, and observation controls. And with our one-way ANOVA, we could compare where are the differences in amongst these 3 means, and that would work this way with the decision tree. So I present here a more complete decision tree that also includes when the data is not normally distributed, which non-parametric tests you might want to consider. That's for your reference if you decide to dig deeper later on. One thing that will help us understand statistical and clinical significance is when the results are precise or not. And so judging precision can be done using non-parametric statistic by looking at the median. So that's the value that splits a rank ordered data set right in the middle. And then the values that represent where the 25th percentile of the data is located and the 75th percentile of the data is presented represent an indication of variability in there. So I won't expand too much more on that, but you can do that with non-parametric summaries. Typical trial sizes are usually set to obtain a width of the confidence interval that will be definitive just enough to decide if the treatment's effective or not. And so there's a relationship between sample size and width of the confidence interval. If your sample's too small, you're going to get intervals that are quite wide, and you might miss some effect because there's lack of precision to see the differences. If your sample is big, you're going to have nice, precise confidence interval, and it will be easier to detect differences. So when judging whether the estimate was precise enough or not, one way is to look at how wide is the limit of the confidence interval compared to the mean, and if it's bigger than the MCID or your estimate of clinical importance, you might have a tendency to say it's too wide. Another way to decide on precision is whether it's precise enough to draw a statistically significant and clinically significant decision. So if we take examples where we're measuring mean changes in an angle where the minimal clinically important difference is 5, we could look at the first example and say, well, this is a statistically significant difference. It's clinically important because the precision of the confidence intervals allows you to say, yes, it's above the threshold for statistical significance and above the threshold for clinical significance. In the second example, we could say, well, it's enough to conclude statistical significance, but it overlaps the threshold for clinical significance, so maybe we didn't have enough precision for the clinical importance. And then in the next scenario, we could say that, well, there's overlap with the 0 threshold, so not statistically significant, but possibly clinically important because the point estimate is above 5, but the interval is not precise enough to be fully confident that we are there. And so you can work your way through different examples that way and see, did I have enough precision to conclude at both statistical and clinical significance? So in the meta-analysis, the authors are going to try to summarize the results from many studies together. One of the questions we're going to have to determine is, were these results similar enough to be compared? One of the tests that can be done is the I-square, and it can be interpreted as the percentage of the total variation across the study due to heterogeneity rather than change. And so if your I-square is too big, and here we'll recommend that if it's over 50%, then it might be too big. But if it's less than 50%, you can start looking at what did the meta-analysis find. So a meta-analysis table will typically give you, for a specific outcome, the means reported in the experimental group and the control group for all of the studies that were combined. So this table shows 5 studies combined. The I-square value was 56, so there's a little bit of heterogeneity here. And if we look at the green dots, we can see, yeah, they're a little bit spread out. Some are significant, some are not. And then we can look at what do they favor. So at the bottom there, it's labeled as favoring the Pilates group. And then we put all these estimates together, we get the summary estimates of minus 7.95 with a confidence interval that's all negative, so it does not include 0. It would be statistically significant mean difference of the meta-analysis in favor of the Pilates, showing a good effect, statistically significant. Then we can look, is this mean effect larger than our clinical significance threshold, to conclude also whether it was significantly important from a disability point of view. So in meta-analysis, again, because we don't necessarily have a specific MCID estimate to use as a reference, there's been an interpretation guide that you can use to interpret mean differences. And so a large mean difference would be bigger than 20%, similar to what rule of thumb we were talking about 30% earlier. And then you can look at standardized mean differences. So sometimes the studies have looked at different outcomes and they're converted to a standardized mean difference so that they can compare different pain scores together, for example. And so this is done using the formula I show here, and then you need to interpret these standardized mean difference score, and then if their values that are as shown here, so larger than 0.5, will usually be deemed a large effect. So to illustrate the standardized mean difference interpretation, I show here studies comparing anesthetic studies to a control trial from 5 different studies, and they had measured pain using different pain scores. So they converted that to a standardized mean difference. If we look at the I-square, here's an example where there's high heterogeneity, and it mostly comes from the Al-Sunnadi study. So we have a flag of that by the I-square of 97%. But overall, when we put all these results together, the standardized mean difference is an estimate of 1.28 in favor of the anesthetic study, and it's larger than our large guide of 0.5, and so we would conclude it's statistically and clinically important effect of the anesthetic using this meta-analysis result. So this slide shows how it works out when you put together the point estimate, the confidence interval, and the precision. So if we take the first estimate at the top where it says it's almost certainly beneficial because the point estimate is over the large limit for beneficial, the confidence interval is tight and it clearly falls into that beneficial range, and so we're quite confident there. For probably beneficial, well, the point estimate is in the beneficial range, but the confidence interval is so wide that we are saying probably instead of certainly. And then you can have estimates on the harmful side as shown here, and then you can have estimates that are kind of in the trivial, not really significant effects, and because they're precise, you could say that you're very confident that this effect is going to be likely trivial. And that shows the interplay between the interpretation strategies we talked about. So in this first portion, I talked about multiple strategies to report the results on continuous outcome measurements in trials of effectiveness. We talked that the mean differences can be statistically significant if the mean difference interval does not include 0. It can be clinically significant if the point estimate is larger than the clinically important threshold, and we talked about where we can find thresholds. And we talked about the statistical significance of our CT can be presented with a variety of tests, but one of the ones we'll need to be prepared to interpret is the ANOVAs, and we've covered that. So because the results of trials can be reported with dichotomous outcomes, we also need to be able to interpret odds ratio, risk ratios, and number needed to treat, and we're going to cover that. Sometimes the results of the effect of a trial can be reported using a dichotomous variable. So that's a variable with 2 categories, and examples of such variables used for trial effectiveness could be success compared to failure, or whether the patients met and exceeded the MCID versus whether they did not. Sometimes they'll report results as categorical, has improved, not changed, or deteriorated, or they'll use a global rating of change or a satisfaction scale with multiple categories, but we'll focus on the dichotomous variables in this presentation. So the most common way to report dichotomous results is using the 2x2 table, and typically we build those tables with treatment and control as rows in the table, and the results as columns. So for example, the event could be success with treatment, and the no event would be failure with the treatment. And so if we report how many patients had success in the treatment group as A, failure in the treatment group as B, success in the control group as C, and failure in the control group as D, we could calculate the treatment risk and the control risk, which would be interpreted as the probability of success in each of the two treatment groups. The risk is a value that ranges from 0 to 1, where 1 means that everyone has had the event. So in our case, it would be very good success rate if we had a risk of 1 in one of the groups. One of the common ways to compare the effect of one treatment over a control intervention is to report the risk difference. So it's defined as the difference in risk between the observation in one group compared to the other. And it describes the risk of success, for example, in the treatment group compared to the risk of success in the control group. And it's useful to report how much more success is observed in compared to a control treatment, for example. So if we work through an example, we could have a treatment group where we observe 99 patients meeting the MCID, so they had success with treatment, and only 1 patient did not. And in the control group, there was 90 patients meeting the MCID with the old intervention, and 10% did not. And so we could calculate a risk difference, and in this case, it would show a 0.09, and that would be interpreted as the treatment group has a 9% larger risk of success or probability of success than the control group. Risk differences usually range from -1 to 1, and they're oftentimes expressed as percentages, and they would range from -100% to +100%. So sometimes instead of reporting risk differences, people report the risk ratio, or sometimes they call it the relative risk. So it's defined as the risk in the treatment group divided by the risk in the control group. And so the risk ratio describes the probability of the event in the treatment group relative to the risk of the event in the control group. So if we use the number for our same 2x2 table presented earlier, we could calculate a risk ratio of 1.1. And that would be interpreted as the treatment group probability of success is 1.1 times the probability in the control group. So there's a bigger probability in the treatment group. Or we could flip that and report that the control group probability is 0.9 times that of the treatment group. So it would be lower probability of success in the control group. So risk ratios will typically range from 0 to infinity, and a risk ratio of 1 indicate that the two group had the same risk or probability of success. So that would indicate a risk ratio of 1 that there's no difference between the groups. So we've presented two methods of summarizing results with Dichotomous. One was the relative risk, one was the risk difference. And you can ask me, why should I care which one was reported? I think it's important because they are not the same. The risk ratio will generally be a larger value. It will look better than the risk difference. And if we only presented results with risk ratio, it will likely be misleading. The patients will more likely care about the risk difference between the two interventions. So if we go through an example, we could see that we could have a risk ratio of 2, which would suggest that it doubles the chance of therapy success when using the experimental treatment compared to the control group. That sounds impressive. But if we go through an example, as I illustrated below here, we could have a group of patients in the control group where 1 patient experienced success out of 50, so that would be a 2% success rate. And then in the treatment group, you could have 2 patients experience success out of 50 for 4%. So the absolute risk difference would only be 2% gained by exploring using the new experimental therapy. But the relative risk would look good at 2 times, doubling the effectiveness when using the risk ratio. So let's be careful about that, and chances are patients will prefer to understand the risk difference. And for example, they might decide to think that the surgery is too burdensome or too risky to undertake if there is only 2% more success when using this approach to using the control approach of doing nothing. In the literature, you will see dichotomous results reported as odds. And so the odds describe how much greater the probability of an event is relative to the probability of a non-event. So they're computed as the number of events divided by the number of non-events. So if we put that in our terms, in the treatment group, it would be the number of success divided by the number of failures. And then we could do the same in the control group. So we would have the treatment odds and the control odds. It's a value that will range from 0 to infinity in each group. And the treatment odds describe what happened in the treatment group, and the control group has its own estimate. So to compare a treatment to a control intervention, we will usually report the odds ratio, and it's a relative or a multiplicative measure. So it describes the odds of the event in the treatment group compared to the odds of the event in the control group, and it will help you judge whether one's superior to the other. The odds ratios are still reported. We would prefer to see risk ratios, but because they're not easy to interpret, these odds ratios. So if we have the data we had earlier and we compare the success and the failures in a treatment and a control group, we could calculate an odds ratio of 11 with our example. And so here we would have to interpret the result a little bit differently. The statement would be the treatment group has 11 times more the odds of success compared to the control group. Or you could say, if you flip it, that the control group is 0.09 times less the odds of success as compared to the treatment group. An odds ratio of 1 would imply that the treatment group and the control group have no difference. So the value for reference here when there's no difference is 1. And they can take anywhere between 0 and infinity as possible values. So your odds ratio compared to the risk ratio are similar only when the events rates are very low. Otherwise, the odds ratio will always be smaller than the risk ratio if we're below 1. And the odds ratio will always be bigger than the risk ratio if we're over 1. So it's typically more sensitive or more extreme than the risk ratio. And they could be converted if need be. But that's the one thing to remember is there are usually odds ratio bigger values, more extreme values than the risk ratios. Similar to what we did with our continuous measures, we can rely on the point estimate and the confidence interval to do our interpretations. So if we're calculating the odds ratio for a pain reduction more than 2 on a 10-point scale, comparing an experimental treatment and a control group, we could have an odds ratio that sits at 11 for the point estimate with a confidence interval going from 3 to 18. And so we could ask the first question, does the confidence interval for the odds ratio or a risk ratio for achieving treatment success from baseline to treatment includes 1? And in this case, the interval does not include 1, so we would conclude statistically significant. We could ask the next question, is the mean difference larger than the clinically important threshold? So if we say, is the odds ratio bigger than the threshold of we want, we could say, well, yes, an odds ratio of 11 is larger than 10. 10 is sometimes suggested as a very important threshold, and so we would conclude there's a large effect as measured by the odds ratio in this case. Shouldn't talk about mean difference, I should talk about odds ratio in this question. So if we want to illustrate the flip side, so what is the odds ratio for observing a pain reduction more than 2 points out of 10 in the control group compared to the experimental group, we could observe an odds ratio of 0.09. So quite extreme, far from 1, below 1 in this case. So they're not likely to experience much such success with treatment. And so the confidence interval for this odds ratio does not include 1, and we would conclude it's statistically significant. We will see in a little bit that one recommendation when we're working between 0 and 1 is to say if it's below the value of 0.5, we will consider it clinically important. And so if this odds ratio is smaller than the value of 0.5, we will conclude it's clinically important. So it's much less likely in the control group that they'll experience benefit from a pain point of view during treatment with the control group. The general guidance to interpret the odds ratio and the risk ratio in terms of clinical importance is the farther away from one you are, the more important the effect is. Generally, we recommend that rather than apply a clinically important threshold to the odds ratio or the risk ratio, you try to judge the importance using the absolute measures, such as the risk difference we covered earlier. But otherwise, a rule of thumb could be this little scale I presented at the bottom, where if the value is above 1 and it's larger than 2, an odds ratio of 2, then it can be deemed large. If you're working below 1 and you're observing an odds ratio that's more extreme than 0.5, so smaller than 0.5, you could consider it large. One more intuitive measure to report dichotomous results from treatment is what we call the number needed to treat. So the number needed to treat is the number that you need to treat in order to prevent one failure. So one example is presented here using our same data from before. And so you calculate the number needed to treat by dividing 1 over the risk difference you had calculated earlier. And so in our case, the number needed to treat would be 11. So you need to treat 11 patients with the treatment strategy experimentally to have 1 failure prevented from the control group. So it's okay, but it shows that the difference in effect between the treatment and discontinued treatment here is not as strong as with some other examples. Sometimes people will report what we call the number needed to arm, and we do that when we report the number that you need to treat before you see an adverse event appear because of the side effect of a treatment. So watch for the label. Number needed to treat, we want that to be a small number, and we like that to describe the effectiveness of a treatment. So the perfect number needed to treat would be 1, because everyone that would receive the treatment would benefit from it and there would be any failure. And generally speaking, when you look for the NNT reported in a study, you're hoping to find low values of a number needed to treat, such that the more patients you treat, almost everybody benefits. So if you have too large a number needed to treat, then there's not many of those patients that will experience benefit, because you would have, in our previous example, for example, we had to try the treatment with 11 patients before 1 failure would be avoided. So when we decide what's good enough, it will depend a little bit on how strong treatment effect was, whether you define success as the patient is fully cured or it's minimally improved. If the cost of a treatment is more expensive, you're going to be more demanding. If there's more risk with the treatment, you're going to be more demanding. You're going to want better number needed to treat. And if there's other alternative treatment that we know are good, then we're going to be expecting much lower number needed to treat before we're satisfied. But general rule of thumb, sometimes we find that number needed to treat of 5 or less in symptomatic conditions can be acceptable, and we have some physio interventions with numbers in that range. So in this second part, we talked about how to report dichotomous outcome on the effect of interventions. We touched on many different methods, including some absolute ones, which we prefer, and some relative ones. So the risk ratio and the odds ratio are relative methods, where the null value, where there's no difference, is 1. For the risk difference, the value is 0. That would indicate no effect. We talked that you can determine if these measurements are statistically significant, clinically important, and precise, still looking at the point estimate and the confidence interval like we did before. And we warn you against focusing too much on the relative estimates. As we try to interpret those, it's always important to understand in that dichotomous success versus failure, how is success defined, so that you get a good understanding of what is being presented to you. Thank you for your attention, and I'll be happy to take questions by email if need be.
I'm happy to provide some last thoughts to this series on evidence in physiotherapy practice. I've been teaching this since around the turn of the millennium. That seems like a long time ago, when I was a teaching assistant from Michel Battier in the University of Alberta's Bachelor of Physical Therapy program. Many of the principles of evidence-informed practice that we teach now and their application are still the same. But I've also seen many changes to how research is done, as well as how we go about finding, appraising, and applying evidence to our clinical decisions. For the most part, things are way better. We have a stronger evidential foundation in support of what we do. We also have way better online tools giving us access to that evidence. We can access papers online, often open access. And we can also often engage directly with physiotherapy researchers through social media. So some things are way better. But there are also some familiar challenges faced by clinicians, which I want to talk about, and perhaps provide a fresh look to renew your evidence and appreciation for evidence-informed practice. One important development in our profession has been the move towards better defining the competency profile for physiotherapists. In 2017, the National Physiotherapy Advisory Group published an updated advisory profile that I love because it highlighted the importance of scholarship. Domain 6 states that as scholars, physiotherapists demonstrate a commitment to excellence in practice through continuous learning, the education of others, the evaluation of evidence, and contributions to scholarship. This presents a lofty goal and raises the bar for all practicing physiotherapists to engage with research evidence and keep constantly learning. The assumption is that we are all physiotherapy scholars, and we need to view ourselves as such. This leads to the questions of what does it mean to be a scholar, and what exactly is scholarship? Scholar and scholarship are dignified words that were thoughtfully chosen for their ability to elevate our practice of physiotherapy and bridge the gap between research and practice. Sometimes when we think of scholars and scholarships, we get images of universities, professors, students, or even the trope of the ivory tower of science. The beautiful thing about Domain 6 is that it aims to overcome this view, making the ivory tower a thing of the past. No longer are scholars only isolated in the halls of universities doing discovery-based research that may or may not have any practical value in the clinic. Domain 6 aims to bridge the gap between research and practice by saying that all practicing physiotherapists are scholars and should be involved in scholarship. There's a great quote from a paper published in 2009 on the role of scholar practitioners. Ruana and Gilly state that scholar practitioners do their work from either the context of academia, where we traditionally believe scholars tend to live, or in practice, where we traditionally characterize those doing the day-to-day work of things like physiotherapy as practitioners live. We must move away from the belief that the setting in which we work defines our work. I want to repeat that. We must move away from the belief that the setting in which we work defines our work. Domain 6 aims to move us further along in our disciplinary evolution. For the most part, we've already transitioned from being competent technicians towards being autonomous and self-regulated professionals. The next step is to expand our role from being professionals towards being scholarly practitioners. So what does this mean from the perspective of evidence-informed practice? Looking further at the specific entry to practice milestones of Domain 6, we see that the first essential competency is that physiotherapists use an evidence-informed approach in practice. This means they incorporate best available evidence, client context, and personal knowledge and experience into their decision-making. I hope that now sounds really familiar, and you recognize these as the three pillars of evidence-based practice. The last two milestones here are related to using structured frameworks and approaches for both making and evaluating our decisions. But I want to talk about the first three milestones. Since the 1990s, the model of evidence-based practice has been visually displayed as three overlapping circles, as seen here. These represent the evidence, the client context, and clinical knowledge. This is great and covers the basic components of the model with the goal of everything aligning and meeting in the middle for optimal decisions. But problems arise in situations where the components don't all match. What do we do if there's strong evidence supporting one treatment, but our client isn't interested, or we haven't had much luck with it? Bodyweight supported treadmill training may be a highly effective strategy for improving gait in children with cerebral palsy, but what if the parents are unable to commit the time required or are perfectly happy with the child's current level of mobility in a motorized chair? Vice versa, what if a client requests a particular treatment, but there is little evidence or even unsupportive evidence for that treatment? I used to see this a lot with people with non-radiating low back pain requesting mechanical traction, when I knew the evidence did not support the use of traction. In these situations, how do we decide what to do? Which circle in the model wins out? Do we routinely side with our clinical experience and what has worked for us in the past? Do we go along with patient preferences, knowing that patient expectations are a great predictor of treatment success? This is one of the most common dilemmas faced by clinicians attempting to make evidence-informed decisions. Very commonly, the model is described as a three-legged stool, with each leg supporting the optimal decision equally. But we all know what happens to a three-legged stool when one of the legs is wobbly, unstable, or maybe even a little shorter than the others. We need an alternative conceptualization of evidence-informed practice, a different model. In 2020, Miera published a paper showing a different visualization of the components of evidence-based practice. Instead of these overlapping circles or a three-legged stool, evidence-based practice is viewed as a sequential three-step funneling process, a funnel. The therapist starts with all of the best evidence and other information available to them. This includes individual papers, systematic reviews, clinical practice guidelines, and other publications that can be found, including qualitative studies, studies of risk or adverse effects, cost-effectiveness analyses, and any other evidence. This feeds into the top of the model. This totality of evidence is then synthesized and deliberated upon in the context of the therapist's clinical expertise, the middle of the funnel. Sometimes this is done by experts in a field and consensus statements are already available, but most often this will be done by individual scholarly practitioners. After weighing the evidence in the context of their own experience, a decision is made and presented to an individual client. This is where the very important process of shared, informed decision-making is done in conjunction with the patient and sometimes their family. Patient values, circumstances, and context come into play. A decision is made, and honest, informed consent is obtained before proceeding with a certain treatment plan. I really believe this funnel of evidence-based practice overcomes many of the problems of that old three-legged stool model. It still doesn't represent the broader context in which decisions are made, including policies and procedures of the clinic or hospital where the interaction is taking place, or the policies of the funder of care related to what is or isn't paid for. But the funnel does provide therapists with a very practical way to view the process of evidence-informed practice, and even provide steps to be taken towards a final decision made, really importantly, in conjunction with the client. I really love this idea of the totality of evidence that was at the top of the funnel. This implies looking at the big picture. From my experience, we tend to think of evidence in a very focused manner, looking only at the hierarchy of studies, randomized controlled trials and systematic reviews up at the top. And we lose the broader information context. In reality, we should be considering all available information, that totality of evidence, looking at the big picture in the context of our own expertise and experience, as well as the client context. Coming back to the essential competencies and entry to practice milestones of Domain 6, I would also like to discuss 6.2, engaging in scholarly inquiry. This is where the gap between research and practice vanishes, and physiotherapists, as scholars, engage in their own scholarly inquiry. This is defined through 6 specific milestones. Number 1, identify ethical considerations related to scholarly inquiry. Next are the evidence-based practice skills of formulating researchable questions relevant to practice, accessing reliable sources of information, and critically appraising that information. And then the last two are contribute to research activities and knowledge management. I want to finish by talking about 6.2.5, contributing to research activities. What does that mean? Does it mean that all physiotherapists should be doing research on their own, developing proposals to test hypotheses, carrying out clinical research, running their own statistics? Definitely not. There's some highly motivated and skilled clinicians who can and do this, but for the most part, leading research projects is well beyond what is expected of entry-level practitioners and most physiotherapists. So how can physiotherapy clinicians, as scholars, contribute to research activities without having to lead research projects? I'd love to hear your ideas, and hopefully we have some time at the end to discuss this. But for now, I'll share some of my own ideas. My first thought is making clinic spaces research-friendly. This includes putting up posters and making other recruitment materials easily available for clients coming into our space. It includes providing access to physiotherapy journals or other sources of evidence to staff, and just generally creating a research-friendly culture in the spaces where we work. My second idea is related to the first, but it goes a little bit further. This is helping to enroll participants for studies. To do this, you need to stay in contact with researchers and learn about what studies are going on in your area. And it may be as simple as posting recruitment posters or other materials in the clinic, but it may also involve things like screening patients, seeking consent to pass their names and contact info onto research teams. This is super helpful when researchers are looking to access clinical populations but can't make initial contact on their own due to ethical requirements. Beyond helping with recruitment, clinicians can also help collect data. This can include helping patients or having them complete patient-reported outcome measures, surveys, administering performance-based or other functional measures in the clinic, or participating in other data collection strategies, whatever it may be. Next, along with helping clients participate, clinicians can also complete research surveys when invited. Now, I've conducted a few surveys of physiotherapists' opinions and practices over the years, and we are usually very happy to achieve like 20 to 30% response rates. It would be fantastic if that were even higher, and that would lead to more valid and representative results. Attending research presentations, including hospital-based rounds or maybe journal clubs, is another great way to engage. Then, of course, implementing relevant findings in your practice is crucial and really one of the most foundational principles of evidence-informed practice. Clinicians can also engage by making friends with researchers and evaluators at your facility, your hospital, or maybe even the local university. Stay in touch with the researchers. We get lonely. We're always happy to connect with frontline practitioners. We often have projects that need clinical input, and we often need advice on how to make our research meaningful to practice. Related to that, there are often really specific opportunities for clinicians to act formally in a formal role on research projects. This may be formal knowledge user on a research grant. In this capacity, clinicians can provide input from early stages to make sure the findings are applicable and relevant, and then very importantly, make sure that the final results get used. Along with knowledge users, quite often research granting agencies require research teams to involve clinician partners as co-investigators on projects. This role, it's similar to being a knowledge user, but more specific to giving clinical input. Next, clinicians can engage with professional associations and other clinical research groups. They can attend conferences and watch the research presentations. And lastly, two other very practical ways to contribute are to act as a screener for systematic reviews or as a peer reviewer for journal articles or for your local ethics committee. Both of these are fantastic ways to see the latest research even before it's published in the case of being a reviewer. Lastly, in my opinion, one of the best ways to contribute to research throughout your career as a physiotherapist is to always maintain your curiosity and an inquiry stance towards practice. There are always new things to learn and possibly better ways to work, to treat, or engage with our clients. Maintaining an evidence-informed approach to physiotherapy practice allows us to collectively, as physiotherapy scholars, advance our practice, provide optimal care, and achieve the best outcomes possible for our clients. Thank you very much for attending, and I look forward to our discussion.
Thanks for those excellent presentations, Doug and Eric. We'll now take questions from the audience. While we give the audience a moment to type in any questions they may have, I'm going to take the opportunity as moderator to ask you a couple of my own. So I'm going to start with you, Eric. You, in your presentation, talked about mean clinically important difference and how that's sometimes applied to group outcomes reported in research, which I thought was a really interesting point that I had never thought of before. So I wanted to ask you, what do you see as the main misuses or perhaps misinterpretations might be a better word, from students and colleagues who are not academic or not working in academia when it comes to the mean clinically important difference? Yeah, MCID, we'll go with the acronyms here this morning. The MCID, risk ratios and odds ratios, like where do we fall down or common misconceptions?
Yeah, that's a good question. Oftentimes, I would say my concern is that we tend to run with a new intervention because it has shown statistical significance without taking the time to try to understand how big were the effects. And so if the studies were big enough and the estimates were precise enough, it could be that they found statistical significance when the effects are really small. So I think just forgetting to look at how big were the effects might be an issue. And then wherever, if the MCIDs are available, then that would be a good guide to help you make that call. It's not an easy call to make as a clinician, but you have to make the effort to try to understand, is it going to be worth it given the burden and the risk of the new treatments to try to run with it? If it's shown statistically significant, you have to look if it's clinically important.
Fair enough. Doug, I know you're a journal editor, so I thought I'd give you an opportunity to chime in on that question. What do you see, perhaps from the research end of things, where there's, I don't want to say, well, I'll say limited reporting or mistakes in what you see submitted at the journal end?
Well, it definitely happens. I think that what Eric was talking about is pretty important, but I think especially with these ratios, one of the things that's required of that is to dichotomize. So you need, a return to work or not return to work or discharge from hospital, not discharge from hospital. And a lot of the outcomes that we have clinically are more continuous. And so in order to use those statistics, we have to carve them up, turn it into a binary outcome. And we're losing a lot of information there. So I think that's a huge problem that I see a lot in articles, just this general loss of information when we try to make categories that aren't there inherently.
Fair enough. You led into my next question a little bit there, Doug, which was around the discussion of risk difference. And I guess, in your opinion, should clinicians either be expecting or be trying to calculate risk difference in every case, or perhaps another way of putting it is be suspicious if an article only reports relative risk and highlights that, given what you commented on, Eric, with the difference between those two measures?
Yeah, so if I can start with that one. Luckily, the journals will oftentimes give you the 2x2 tables, so you will be able to have a quick look. And so I encourage you to look beyond the ratio information. The other thing to look at there is, luckily for us as physio, oftentimes the means are reported as well, so we're able to look a little bit further. But when there's just a ratio, if you don't get the numbers of who benefited, you have to be a little bit leery. I remember my wife had an episode where a doctor was trying to advise her whether she needed the new surgical intervention, and presented as risk ratio. It was really enticing to go for the surgery, but presented as a risk difference, once factoring the burden of and the incapacity that would follow the surgery, she chose clearly not to go ahead with the procedure, judging that the risk difference gain was not worth the risk and the burden of the treatment.
It's better than just a p-value, I would say, but I agree with Eric. You do need to go and look at the raw information as much as possible, those mean differences or the more absolute value of how big of a difference this intervention is making.
Fair enough. That's a great comment. Yeah, you made me laugh with the reference to the p-value, because I think one of the big takeaways from this series is the p-value is just not quite good enough anymore. I want to move on to talk just briefly about the funnel model of evidence-based practice. And, you know, I commented to you, you had shared that model with me previously, Doug, and I think it's a really interesting, fresh take on evidence-based practice. And I'm wondering if you highlighted the pros of the model, but do you see any cons to adopting that model or moving away from our three-legged stool, or is this the direction that clinicians really ought to be starting to move towards?
Well, I kind of think that this is what clinicians naturally do, right? One of the limitations of the older models, I thought it was quite artificial, where you're trying to look at all these things simultaneously. That rarely happens, right? We have this background knowledge, we have this background evidence and information that gets funneled through our own viewpoints, our own perspective, our own experiences, and then ultimately presented to the client or patient. Right, so I think that the new model, the new way of looking at it is actually more natural. It's what goes on in clinical practice. If anything, the big limitation would be a minimization of evidence. Right, it seems as if the key decision happens right there at the bottom of the funnel with the interaction with the client. So if anything, it might be deprioritizing the evidence component.
Okay. Well, we haven't got any coming questions from our audience this morning, so I think, given that it is 9 o'clock, we will say goodbye for today, and thank you for joining us this morning. We really appreciate the presentation, and wish you all a fantastic day. Thanks very much.
Thank you, Leanne.
Thank you, Leanne. Have a great day, everyone.